of my colleagues who help to lead the American Palliative Rehab Alliance, I'm Lori Boatwright. I have Chris Wilson and Ann Henshaw here as well. And we are delighted to bring together some really wonderful professionals to present this evening. And we'll also have a chance to do some engaging Q&A when we get to that part of our evening. I'm just checking my notes to make sure I'm doing this properly. We also are pleased to partner with APTA Oncology's Hospice and Palliative Care SIG, as well as the AOTA Community of Practice in Palliative Care, to bring this presentation to you this evening. Some general housekeeping. We will have about 30 minutes of content this evening, and then again, followed by a question and answer session. We can, however, keep the session fairly casual. If you have a question, please keep your mics on mute unless you have a question. I guess that's good advice as well to minimize the background noise for our presenters. But do feel free to unmute yourself and ask a question should it arise during the presentation. Chris Wilson will be recording the session. So here's your reminder, Chris. You can go ahead and hit record when you are ready.
Way ahead of you. You're already recorded.
Okay, perfect. And I also just call your attention to the chat because we will be providing some updates and kind of teasing a little bit of our next presentation, which will occur in September. So we'll be providing some information on that. So welcome once again, and thank you for attending tonight. Without further ado, I would like to introduce Ann Henshaw. And Ann, I'm not sure exactly how the group was going to introduce, but if you would kindly maybe take the lead in introducing your esteemed colleagues, that would be wonderful.
I certainly will. Thank you so much, Lori. And thank you everybody for being here on this summer evening, although it's rainy here. I'm in Boston right now. We appreciate your time. We appreciate your passion for this population, really, and for serving this population that in our minds, at least, really deserve palliative rehabilitation. So that's why we're really all here. My team at Georgetown, and they will introduce themselves as they go along, but tonight we have Dr. Kay Loon, who's a palliative care physician, and Dr. Morgan Kempster, who is a physical therapist. Sadly, we do not have Sheron today. She had something come up, so we will, Morgan and I will be playing our best speech therapist. And I know I have Anna on here too. I have another speech therapist colleague. So when we get to those places, Anna, feel free to jump in and help us clarify, because we do work closely together, but I am not a speech therapist.
Thanks, Ann.
Anyway, so we are just going to sort of talk pretty casually about what we've done to try to build bridges from the palliative care team and the rehab team. So it's really a conversation, and we hope you jump in. Anything that we talk about tonight, we are happy to share as well. Okay. So Morgan, why don't you advance? I think you're my advancing, right?
Yep.
So here's our objectives for tonight are really just to talk about the barriers and facilitators to this interprofessional communication, to try to come up with some strategies to enhance collaboration, some action steps. You know, as therapists, we're all about action steps, right? So I want you to hopefully go back to your facility with a plan, with an action step to really, even if it's a small one, and really to try to improve care, because that's the ultimate goal. Here we are in our beautiful circles. And how this all started is, you know, really part of my doctoral capstone project was that, you know, rehab and palliative care just weren't talking to one another in an effective, routine manner. You know, we might have one-off conversations, but we really weren't working together systematically. So that's what this all really is about. And, you know, that led to underutilization. And what we found is that we were seeing very similar patients, but we were doing it in parallel. So we were just trying to build that bridge. And so that's sort of our mission statement or our aim. And I believe I hand it off to you now, Dr. Kayloon.
Yes. Hi, everybody. My name is Bree Kayloon, one of the palliative care physicians at Georgetown. We wanted to start by talking about just some definitions and trends in palliative care and rehabilitation. So you can go to the next slide. As I'm sure a lot of you know, there are a lot of myths and misunderstandings about palliative care. So when I'm discussing palliative care with my patients and families, I describe it as an extra layer of support that is meant to serve people living with a serious illness. And we focus on quality of life, whether that's physical, emotional, spiritual. It doesn't require a time frame like hospice does. So in palliative care, we see patients at any stage of illness. Some of these patients have early stage disease. Some of them were just diagnosed a couple of days before I meet them, but they don't require a time frame like a month, a certain amount of months of prognosis for them to receive palliative care. Patients receiving palliative care can also receive their disease-directed or life-prolonging treatments. So these patients are still getting chemotherapy, they're still getting hospitalizations, most of them are still full code. So their goals are aligned with continuing with disease-directed interventions. They keep the same providers, and palliative care from a subspecialty standpoint is a consult service. And then it doesn't change payment or insurance, unlike hospice, which we'll get to in the next slide. Hospice, on the other hand, is a service and an insurance benefit for patients who are in the last 6 months of life who have a terminal illness, but it does require a time frame. It also requires that a patient is no longer pursuing disease-directed or life-prolonging treatment specifically. So the focus is on comfort, quality of life, just like palliative care, but they're usually in the home setting or somewhere that they call home, focusing on comfort, not going back to the hospital and no longer getting their disease-directed treatment. Patients or families as surrogates will elect for this and enroll in hospice, and it is an insurance benefit through the Medicare hospice benefit. So some people ask me, well, now I understand what palliative care is, but what is it that you actually do when you go see a patient or family? A lot of the times we are doing symptom assessment and symptom management. So pain, nausea, vomiting, sleep, anxiety, shortness of breath, itching, it runs the whole gamut. Psychosocial and spiritual support. We do have social workers and chaplains on our team. We're very lucky to have them to address psychosocial and spiritual needs of our patients. And then a lot of what we do is goals of care, which is a huge umbrella term. But if I were to define it, I would say it has a few different pieces. One is disease state understanding and education. So what does this person know about what their illness is and what their prognosis is and what the natural course of the disease process is? What is the prognosis? What are the person's values as it pertains to their life, their illness, and what they want that to look like? And then you can get to medical decision making. So we take, where is this person in their disease process? What is the prognosis? What are the values, understanding this is where they are in their disease process? And how do we come together to make a plan that matches both where they are in the disease process and what they want for this part of their life? We help with surrogate decision makers. Sometimes it's a little more gray area than others. Advanced directives or living wills. And then patient advocacy and coordination of care. A lot of what palliative care is doing is helping everybody come to the table to help the patient's family members understand what exactly is going on, organizing family meetings. Next slide. And this describes the palliative care continuum of care. So on the left side, somebody is diagnosed with a life-limiting illness, and palliative care can get started seeing these people as soon as they're diagnosed. Their palliative care needs might be smaller at the beginning, and then as their disease progresses and potentially they have more uncontrolled symptoms, or they're getting closer to end of life, or they're no longer tolerating their treatments well, palliative care might have a larger role in their care. So the palliative care interventions kind of go up. And then when they get to the last 6 months of life, if they elect for this, they can enroll into hospice care. And hospice also has bereavement support after the death of a loved one. Next slide. So here's some new trends in palliative care and hospice. So one of them is that cancer and a lot of chronic illnesses are actually, or a lot of illnesses that used to have a shorter time frame are becoming chronic illnesses that people live with for years and years and years at a time, because luckily we've developed so many new treatments for these illnesses that used to result in a shorter time frame for patients. So while these patients are undergoing their treatments for those years and potentially declining for those years, they really do need some support along the way. There's a significant growth in outpatient palliative care, which I'm super happy about, because I think if we can get to patients and manage their symptoms, help with advanced care planning and support before they're in crisis in the hospital, that's always the best. A lot of patients now have multimorbidity, so it's not just that they have cancer and that's it. They have a lot of other things going on in addition to their primary diagnosis. People are living longer, so they have more palliative needs. And then what we're really excited about is an international push for rehab and palliative care. So we'll talk about that as well. So what we would like to do is shift the thought that rehab is separate from palliative care to the fact that rehab should be integrated in palliative care for people with serious illnesses and their families. Because traditionally, when we think of the palliative care framework, it's always been interdisciplinary. Physicians, nurses, pharmacists, nutritionists, chaplains, social workers. But there's really a piece missing to this puzzle, because when I ask my patients, what is it that is important to you? They almost always say something like, I don't want to be a burden, or I want to maintain as much independence as possible. I want to be able to do this, this, and this specific tasks. So having somebody who specializes in that has been instrumental in helping with quality of life for these people. Next slide. And I don't know if some of you have seen this already, but we were happy to see that we weren't just making this up in our heads. This is something that is internationally being supported and researched. So the World Health Organization in 2023 released a policy brief that palliative rehabilitation should be a right for all patients with serious illness, and that there should be policy and guidelines to support incorporating rehab into palliative care, patients with chronic life-limiting illness, creating curriculums to teach both palliative care and rehab professionals about the importance of palliative rehabilitation, support careers in rehabilitation, and also create frameworks or examples of interdisciplinary and coordinated care between palliative care and rehab. Next slide.
Is this me or you, Brie? I don't know.
That's you.
Okay. Can people hear me? Because Chris tells me I am being quiet, and that is not like me. Anybody on this call that knows me knows that usually I'm being
perfect.
To be quiet or not to be louder. Celia says, one of my students is saying she can hear me. Thanks, Celia. Okay, so what we first did, at Georgetown, and we're really going to talk to you about what we've done at Georgetown, what's worked, what's been hard, what's been less hard. I won't say easy. So we looked at the barriers. What are the constraints to us not working well together or not routinely, effectively collaborating with one another? We all know that time is a thief. It's really, the biggest barrier. The other barrier that we noted was, education. Do we know how to do this? Do we know how to collaborate with one another? Are we confident, especially some therapists over others? Are we confident in doing it? Does our system, our EMR, set us up to easily communicate? We'll talk a little bit later about teams and how that does and does not. And do we really understand what one another do? Do we as therapists really understand palliative care? Does palliative care really understand what OT, PT, and speech does on a day-to-day basis, and what our scope of practice really is? So those are the barriers we look to address. The good news was that we really aligned on so many things. We shared values. We were all motivated to work together. We, for the most part, had fairly good communication skills. And I'm not just tooting our own horn. I mean, I think research supports that palliative care physicians and rehab physicians and therapists, are fairly strong communicators. We all have a holistic and person-centered approach. And there's not so much ego in this space, like there may be in other of our colleagues' spaces. We really want to work together for the benefit of our patients. So that's sort of what we set out to do. Next slide. So what we've done, we have a nice fade. So yeah, more about our aligned goals. I don't know that these are a surprise to anybody on the call, right? All palliative care goals our goals, and oftentimes hospitalist goals as well, if we want to bring them in, or other physicians that are working with in acute care setting, because that's where we're the framework from which we're speaking. We want to facilitate independence that matters, though, promoting participation and safety and quality of life. So we really found that our goals were so aligned that working together, once we figured out some logistics, was not that hard. Next slide. So the first thing we did, and we're going to talk through a little bit of these, was some educational training. So bottom line is we had to, and these we've learned now have to be repeated, because guess what? We have new staff and new policies and new things happen. So they do have to be repeated. So it's not a one and done thing. But we did in-services from the palliative care team to the rehabilitation team, and then from the rehabilitation team to the palliative care team. And they were just wonderful social events to also, the byproduct of that was we got to know each other a little better, right? We saw faces in the hallway then that became more comfortable talking to. So that was one of the things we did. This one I think is you, Bree.
Yes. So I had a really great time leading these goals of care training or communication training sessions for PT, OT, and SLP at Georgetown. We had 3 different sessions. We separated into each discipline. We had a didactic portion where we talked about what our worries were, what their worries were about communicating with seriously ill or dying individuals. We discussed specific communication tools that were adapted from Vital Talks, which is an internationally known teaching service for communication in palliative care. And then we practiced those communication skills with case studies. And so it was a really fun session, and we were able to do pre and post surveys. And it turns out that even with this hour-long intervention, because nobody has a lot of time for this type of training, there was a significant improvement in people's confidence in initiating these conversations. So you can go to the next slide. I just want to give an example of some of the communication skills that we discussed and practiced with the rehab professionals at Georgetown. Because I think that PT, OT, and SLP are really well positioned and well suited to do things like get a sense of what a person's understanding is of their illness, respond to emotion, because they're often in the room when the patient is realizing for the first time they can't do something that they did before, so they receive a lot of emotion. And assessing values and what's important. So we talked about an ask, tell, ask, a remap, nurse statements, and then wish, hope, worry, wonder. So if a patient is saying something that they're hopeful for or that they're hoping is going to happen, and in your mind you're like, I just do not see that happening. Like I imagine a lot of times they say, I'm hoping I can go to rehab and just get back to where I was before. And so we did a lot of wish, hope, worry statements where we said, well, maybe then we can say, I hope that you are able to move around a little bit more and maintain some of your independence at rehab. And I worry that this disease seems like it's progressing pretty quickly, and it might be hard to get to exactly where you were before. Can we think together about other goals that we can set? So that was a really fun session.
Hey, so I'm Morgan. So in developing a lot of these kinds of things that we were doing at Georgetown, it was how do we get this information out there? So as Anne briefly touched on, we developed our team's communication channels so that we had a very clear, direct line of communication between the rehab team and the palliative team so that if we spotted something, we could immediately get them involved and vice versa. But we can't really be kind of the net that catches everything. So how do we get other people involved? So we started doing collaboration with nurse educators and nurse managers on the various units. And they started giving us some ideas, and we toyed around with the idea of, well, do we make a 10, 15-minute webinar that we can shoot out to everyone in the hospital? And we're still toying with that, but some of the nurse educators are saying, well, I mean, people just kind of hit play and they walk away. So do we need to develop a one pager that is circulated in like break rooms and staff bathrooms. And they said, yeah, like that really kind of puts the information out there more and people tend to read those a bit. And then we started doing a little bit more unit specific education. So the presentation that you're seeing tonight is sort of a modified version of one that we've given in various units, but we tailor it specific to who we're presenting to. So for this evening, we're not teaching you what PT and OT are. We're going to touch on a little bit of what we do in the palliative realm, but we go into these units and we say, here's how we could be engaged in an IMC or an ICU. We're not really showing up on the ortho unit too much, hopefully. And then we also go into the nursing school that's next door. Luckily at Georgetown, it's very convenient for us. We have the nursing program right next door, and we're meeting with bachelor's and the master's students, and we're showing them how we can be involved and how they can get us engaged, and they can be the eyes that catch these things that maybe other people aren't seeing, so that when they start practicing, they can be on the lookout.
And sort of to recap it, when you say on the lookout, they can be realizing, I think, Morgan, that it's not palliative or rehab, right? That they're not binary choices. I mean, that's really our messaging, because a lot of times nurses like, oh, they went to palliative care, they're going home with hospice, they don't need you anymore. Well, we beg to differ. You know, we really think we can continue to add value. Anyway, so what we've done, this is sort of our playbook, so to speak, right? The things that are in yellow, we've begun pretty aggressively, or I never say completed because life is an iterative process, right? The educational in-services, we've done one round, sort of 1.5 rounds maybe. We're probably on round 2 in September. We've tried having therapists go to rounds with Dr. Kayloon and her colleagues. Logistically poses a lot of challenges, which I'm still fighting a little bit, but so attending rounds on some level, whether it be weekly or every other day or for certain patients or whatever, we're working on. The teams, number 5, the EMR communication tools, that using teams to communicate with one another in real time. And then the goals of care training, number 7, that Dr. Kayloon has done with the therapist. Other things are still in process. We'd love to know other things that are happening in your sites. Identifying champions, number 6, it's sort of who's sitting at the table right now with you, right? Are we always looking for more champions? Most definitely. Anyway, and there's the number 9 is sort of my ultimate goal of really having an embedded rehab therapist on the palliative care team. So if anybody has that, we would love to hear about it and how it worked and how it's billed and all those fancy things. Anyway, so that's our playbook, and what's next? I thought we were moving this slide to the end, but we can probably leave it here. So bottom line is we are trying to infuse the rehab lens throughout the palliative journey, okay? Whether this is a patient that's going for more curative treatment right now or trying to get stronger to do so, or maybe heading toward hospice, we're really looking at anticipating that need. And as Dr. Jessica and Dr. Kayloon at least both know, we need to have prognostic information to do that. Like, we need to know where you folks are in your thought process regarding that, so that we can anticipate decline if that is indeed what's happening. Also, we want all, especially palliative care providers, to know that OTPT does address fatigue and sleep hygiene and psychosocial issues, so that you can bring us in for specifically those reasons, and not have the mindset that, oh, the patient's, it doesn't have the energy to participate in rehab, because Chris and I will blow smoke out of our, and Lori, right? The energy piece is really sometimes a barrier for providers. And we are here to say that we can help with pacing and with energy conservation and with all sorts of tools, and both educational and otherwise, to help in that space. Additionally, Morgan and I do a lot of work on pain management, not just, obviously, the docs are given the pain meds, but when you take your meds and other positioning and things like that might, non-pharmacologic pain management, like mindfulness-based interventions, are definitely something that OT and PT can add to this palliative care space. We are always advocating for helping patients take some charge of their legacy and what they want their decline to look like, so that what we've learned and what the research supports is that, well, we're all going to die. We know that. But if we plan for it, if we have more information, we reduce our anxiety. And when we reduce our anxiety and we have a plan, guess what? Patient feels better, family feels better, team feels better, for the most part. Facilitating socialization is a huge part of why you might engage OTP to your speech, specifically speech, especially if we're talking communication. And really looking at what the patient specifically wants to participate in, not just that they can be independent as a goal, but what do they want to be independent with? Okay, that's my spiel of what OT looks like in palliative rehab. Bria, you're going to do the case study? Start it and then we'll talk about it later, or?
Yeah, I'll start it and then we're going to come back to it. So we wanted to give an example of a case where rehab and palliative care can really we're able to come together and have a good outcome for a patient. And this patient might be familiar to a lot of you. He was a 49-year-old music professor who had newly diagnosed colon cancer. And he had had treatment, but even with treatment, it had progressed to the liver and spine. He had a lot of bony disease in his spine that was causing pain and reduced mobility. And he also had mets to the brain, which were causing sort of on and off cognitive issues, including memory. He required a lot of assistance in terms of being able to stand up and do self-care. He really wanted to go home with his partner. He had been to rehab and did not have a good experience there. And so his goal was to really be at home as much as possible rather than facilities. He had a lot of pain and anxiety that were limiting his mobility and participation. And then the neurosurgery team removed the spine lesion. And then they said, PT/OT, can you help us with dysphorexia? So we'll think about that case for a minute and then come back to it.
Yes, I guess at this point, maybe a little stop. You had put something in the chart there, chat, Morgan, just to throw out to folks, these sort of questions. Do you know if you have a palliative care team in your hospital? Do you know how to get a hold of them? Do they know how to get a hold of you? Are you involved in goals of care conversations? Anybody want to jump in and we can test the water?
Hi, Anna. I can start for you. This is Anna.
Hey, Anna.
Anna and I got our doctorates together, though I'm an SLP, so I was about a year behind her. My doctorate was in management of dysphagia and end-stage dementia, so swallowing disorders for patients who have reached the global deterioration scales of like 6 or 7. My current hospital, my main hospital, had a palliative care NP dedicated. They have eliminated her, of course, because I work at a for-profit hospital. So yes, I knew her, she knew me, we worked very closely together, and now it's really just me, but obviously I only see my patients. I don't see every patient who's appropriate for palliation. I'm very involved in goals of care, especially if the patient has dysphagia, talking about how much the patient wants to eat and at what cost. I personally am very libertarian about diets. I think the evidence bears that being on a PO diet and risking a little incidental aspiration is much better than being strictly NPO for a variety of reasons. So we don't have palliative care. I'm makeshifting palliative care, a palliative care approach at least with dysphagia patients. Whether or not they have dementia, though, that is my personal interest. And so I start a lot of conversations with a lot of these tools about, we hope your swallowing can get better. In the meantime, or in concert with, if it doesn't, what risks are you willing to take to maximize your quality of life? Our PT and OT so much aren't currently involved because they're just little discharge machines, unfortunately, for-profit hospitals. But I think given the opportunity, they also would like to approach a lot of our patients who get labeled as difficult or non-compliant. I think they would like to have these sort of conversations to really focus on the patient's goals and not just throughput.
Thanks so much, Anna. That is just a snapshot of a hospital, right? That is functioning right now somehow without any of these beautiful things that the World Health Organization thinks should be in place, right? Did Tim have something in the chat?
Yeah.
Lori,
Um, and just to follow up with you for just a sec, I wish LaSharon could be here. I have her notes for her slides, and so many of the things you said resonate so perfectly with the notes that she has. So yes, you'll be hearing some of those things back at you in a little bit. Yeah, Tim asked in the chat, how does the therapy team best promote the benefits of therapy to providers caring for palliative and end-of-life patients? What has worked for you? Um, I think from a PT standpoint, we already have such a great relationship with Bree's team. They know all the things that we're doing in terms of the benefits of mobility, and we'll cover a little bit of that in some of our later slides, and some of the various other things that we can do. But advocating to maybe some of the other physicians who aren't as familiar, it is really about approaching them, or teamsing them, however we need to in terms of communication and advocating and saying, well, if we come across an instance where a patient was placed on comfort care and our orders were discontinued, finding that physician and saying, hey, like, I'd really like to discuss, is there something more that we could be doing? And maybe we aren't focusing on a functional goal anymore, but we're focused more on how do we make the patient comfortable? And there's a lot of things that we can do in that realm, or breaking down our goals to be much smaller than what I think a lot of PT and OT has become in the hospital. Like Anna mentioned, we kind of have these discharge machines, and it's focusing on the little things.
Tim, I think the other thing that I find is effective is really, when they're deciding maybe that we don't have utility, is tell me about the patient. Go in with sort of a voice of curiosity. And if they start saying pain, or if they whatever all the way down to Bree's itchiness, right? Tell me about the patient. Tell me what they're struggling with, and I would bet there's something I can pick out there, whether it's a mindfulness app, or maybe the mindfulness app is not for the patient, but it's for the wife or husband or friend that's sitting there, or some way to add value, right? Because I think we are, OT, PT, and speech, we are very good at finding ways to add value. And it might not be a big change, but we can probably make that person's life just a little better in that moment. And that's really what we're about. So really not forcing it, but stepping back and asking from a curiosity lens, tell me about what's going on. Let me see if I can help. So anyway, not sure that's helpful. You can keep going there, Morgan, if you
Celia asks, curious how goals of care shift as a patient's cognitive decline progresses. From a therapy side of things, our goals are going to change just to accommodate that cognitive decline, and maybe we aren't working on tasks that require as much of a cognitive component to them. I don't know. Bree, do you want to take that question?
Sure. I mean, from a palliative care standpoint, one is obviously we go from talking to the patient about their goals and decision making to a surrogate decision maker, which is a huge change and can have its own complexities. But also, just like any kind of decline, whether it's physical or cognitive, setting new benchmarks and new goals along the way. So if the goal previously was for them to be able to do IADLs or ADLs independently, we would say, like, well, if that's not something that's possible, what are goals that are going to fit within what's possible, given this cognitive decline? So the goals would shift as the patient's cognitive decline shifts as well.
Okay. We'll do one more question before we continue on with our slides. Veronica mentioned, I'm currently doing a level 2 in acute care, and I've noticed that when patients on my list transition to comfort care, my clinical instructor has a sign off on them, much to my dismay. Me too. I've been advocating a lot more for OT's role, space in end-of-life care, specifically hospice, but I don't have a lot of practical knowledge in what comfort care really looks like. My CI says that if they go on hospice but plan to go home, we would see them for family training. I hope they do. But if it's comfort, there's not much of a need. I'm conflicted because I don't actually know how much time capacity a patient has apart from caregivers for interventions, even if they aren't rehab focused. Um,
I want to
well,
meet
I
Monica.
I hope that your CI stops just signing off. There are times when we have done all the things that we can do, and it is time for us to take a step back. But there are so many steps before that, rather than just seeing comfort, sign off, we're done. I think there are a lot of steps that we'll cover some of that in some of our later slides. Um, and in terms of how much time capacity a patient has, that's so much of a conversation with the palliative team and the physicians. Uh, Bree, do you have any more insight there?
I think that Morgan and Ann seems to do a good job of tailoring it to the patient's abilities and wishes. There are some patients who even though they come in and the patient is comfort care, they don't necessarily want to participate in rehab, or some of them really do. So I think it's just patient specific.
All right. Celia, I'll just answer yours real quick because I know it's a quick one. Do you have experience with goals misaligning between patient and the caregiver? Yes, it does happen, and it happens all the time. And there's a lot of conversations regarding what is everyone aiming to do? What are the goals of the patient, goals of the caregiver? What are the therapy goals? And where can we find the happy spot, the medium between all of those to really see what's the best for everyone?
And that's where palliative care really shines, in my experience. If they're being followed by, hospitalists and some other internal medicine team or whoever it might be, and this confusion is going on, even if the patient has, sort of light palliative care needs, to me, it's a great way to say, Dr. Kelly, could you come in? Because let's see if we can just get people on this, maybe the same page, but aligned a little bit better, specifically for the patients concerned. And oftentimes what we find is, patients might tell Morgan or I or Sheron or some of our other therapy colleagues, I know my daughter really wants me to keep working with you, but I'm so tired. I've been fighting for this, and those special things that they say in our confidence, because, right, I'm an OT, I'm in the bathroom with them, I am toileting with them, we are shaving together. It's an intimate space, right? And they might share things of really what's deep and meaningful. And my ability to bring that to the palliative care team, to the team, and help the family understand that patient's concerns and stuff is in my mind a privileged position. It's a beautiful thing to be able to do for that patient, because they might be worried. I don't want to disappoint my daughter. I've literally heard patients say that. I don't want to disappoint my son. I know he wants me to work hard. You've been working hard for 90 years, right? Maybe. So really being able to sort of bring some light on that is beautiful work. All right. Are we moving on here, Morgan? You chopping the bit. I mean, I've talked a lot here. Our goal, OT and all the OTs that are out there, we're doing amazing work. We are really having people participate more as their days are numbered, as they near their end of their life. We don't care how well they're doing something. We care that they're doing something, whether that be being in their garden or brushing their own teeth or whatever they tell us is important. So meaningful participation in the world that they've built is really what we're looking at. We're obviously working with physical therapy on desired mobility. We can do a ton for pain management, non-pharmacologic pain management. And if you're in a hospital where the palliative care team or the hospitalist or whoever doesn't know that you can help with pain, please advocate for OT. We can do a ton of things for pain. We can't give meds, but there's so much other things that we can do in that space. To Veronica, I think it was, point on caregiver training. If nothing else, when we go comfort care, that's something we can hopefully do is at least one session of working with their family if they're going out to help with training. Sleep and fatigue management, I mentioned. Social connection, I mentioned. And really, we may be the only person that asks them, What do you like to do for fun? What brings you some joy? I can tell you, Morgan has heard me say that to patients probably 1,000 times as we work together. I can't fix everything, but what can we do that might bring you just a little bit of joy? And I usually get some really cool answers. Maybe it's baseball, because I'm a baseball person, or maybe it's a hot cup of coffee. I'll do that too. All those things that really in that space just make that person's life a tad better. And that's really what we're all about here. All under the umbrella of family training and psychosocial support, obviously. All right, 30 seconds. And what is OT?
For physical therapy, getting back a little bit to Anna's point on discharge machines, unfortunately, that is so much of what PT and OT are coming in and doing. They're evaling, they're getting people up, doing some mobility and saying, here's the discharge plan. Great, moving on, next one. And when we're moving into this palliative role, there is still some focus on the functional mobility aspect of it, and that is part of that discharge machine. But it's a huge mindset shift to focus on all the other littler things. Not littler, but things that most PTs are really not focused on. So it's in conjunction with our OTs working on pain management. Can we do something in terms of breathing exercises or mindfulness to shift the focus away from that pain? It is doing caregiver training, especially for our palliative care patients. They're going home, they need extra resources. Family doesn't know how to use certain things or how to do certain actions in order to help their loved one. Training them on the equipment that they need in order to do that stuff. And then thinking about fatigue management. So many of the tasks that you and I take for granted are now a laborious task for our palliative patients. And it might be that we need to break those tasks up into smaller parts with rest breaks built in. And then part of PT that I love and almost every other PT hates is integumentary wound care. So if you really want to deep dive into it, we could do that and we could do all kinds of wound care and we could train the patient and the family, but we could also just prevent a lot of that. And so much of it is positioning and just if we get them moving a little bit, it has the benefit of avoiding those wounds and just a little bit of activity has such huge gains for the rest of the body, your muscle, heart, lungs, all of everything in your bloodstream. It just all works better. Uh, Now to channel my Sheron for a moment, um, SLPs, they're targeting the prevention, the assessment, diagnosis, and treatment of speech, language, social communication, cognitive communication, and swallow disorders, with a heavy emphasis on swallowing. In an inpatient setting, roughly 85% or more of the SLP interventions are targeting swallowing. And these issues with swallowing, feeding, or eating can pose an adverse risk on quality of life, medication administration, dehydration and malnutrition, risk for aspiration, pneumonia, and in some instances, death. Now, getting into the decision making, their swallow assessment and recommendations help shape the plan of care for eating and drinking candidacy, medication administration, tube feeding, and broader goals of care. And it's critical to understand the factors that drive that decision making, not just did the patient pass their swallow eval or not. And aspiration is a big buzzword in the hospitals, but the SLP assessment dives quite a bit deeper. The SLPs are conducting a risk-benefit analysis and asking who is truly at risk for illness related to eating and drinking and why. Aspiration isn't necessarily the boogeyman. Aspirating doesn't automatically disqualify a patient from oral intake. It's about weighing the patient's individual risk factors. The swallow eval is more than observing someone eat and drink and often begins before the bedside. The SLPs are looking at the chart for underlying comorbidities and the reason for hospitalization at bedside, and in collaboration with PT and OT, they assess functional status. So they're looking at mobility, respiratory status, cognitive status, and self-feeding ability. Limitations in any of these areas increases risk for dysphagia-related illnesses.
And nutrition plays such a big role in goals of care. Almost every goals of care conversation that I have, I feel like there is some either family or patient distress over dysphagia, not wanting to eat, not able to participate in meals. And so it's something that SLPs can help with a lot because of their experience in the diagnostics that they're able to do in the hospital. So I have more and more been inviting our SLP colleagues to our family meetings, particularly where we're discussing things like PEG tubes or dysphagia causes or prognosis, so that they can hear directly from the patient and family can hear directly from the experts what exactly is going on and what the teams feel like is the prognosis in terms of their swallowing ability and able to maintain nutrition on their own. So Sheron and her colleagues have been so wonderful about doing a pre-meeting with us so we can talk about what message we want to send to the family when it comes to nutrition and eating, asking their understanding of the plan. They were able to share their assessment of their bedside swallow evaluation and some of the more specialized studies that they've done. And then they're also able to answer really specific questions that come up during these family meetings that I do not know the answers to. So having SLP involved in goals of care discussions, particularly when they are about feeding and nutrition, has been immensely helpful. All right, so we're going to go back to this case study, Andrew. So this is the 49-year-old man who has metastatic colon cancer. He has progression of disease. He's having functional decline, potentially cognitive decline, and neurosurgery does the thing. And then they said, okay, get him out of the hospital. But in this case, our PTOT colleagues paused and said, wait a minute, how is this person going to be successful at rehab? They can't exercise, they can't do the exercises because they're in pain and they have anxiety. The patient has been saying he doesn't want to go to rehab anyways. Is there a better way that we can take care of this person and his husband? So palliative care got involved. We talked with PTOT about what the concerns were. We were able to get his pain under better control so that he could actually work with rehab a little bit better. And then we also recommended having a family meeting to address some of the concerns that PT and OT had recognized in their sessions. So in the family meeting, the oncologist said that there are no further surgical radiation or chemotherapy options that can be offered. And he said he would like to get out of bed and walk. He was previously active and independent, but before we were involved, the pain was limiting factor as well as distress. So we were able to recognize what the patient's values are, what the medical situation is, and then talk to him more about what the options are in terms of next steps. So you can go ahead and click. So here's how each of our teams sort of conceptualized and helped Andrew and his partner figure out what the next steps are. So in conjunction with the oncology team, from a palliative care standpoint, we're saying the CT scan shows that the cancer has spread further, and unfortunately, there are no more treatments that can stop or slow it. So just being as direct but as compassionate as possible about sharing prognostic information and what we can do in the situation. And then I'll let my colleagues take over.
And just for those educators on the call, because I know there are some, we use this format a lot, like with the nursing team as well, to sort of just layer our lenses on top of one another. And they're not distinct, right? We all know that, but it just gives us some texture, especially for OT, which is, as we all know, very misunderstood, and palliative care sometimes as well. So just so that people sort of understand what angle we might be taking, what our lens might bring to a given case study. So with Andrew, I mean, he was so scared, so anxious, and in so much pain. Getting him to the edge of the bed took, PT and OT max assist, and we're looking at each other going, what are we doing here? Like, this is crazy, right? So really just stopping sometimes. And I know, Anna, to your point, we are discharge machines. It's a Friday afternoon. We got to get him out the door. We get that. But just stopping and saying, Andrew, this stinks. Like, what's going on? What's important to you? What should we be focusing on, right? And where do you want to spend your energy? Because it is limited, right? And really having that discussion and getting him home and getting him home with his partner and partner training and, all the things that we do anyway in terms of what we need. He had stairs, so we had to have a stair lift, and we had, all those things we do anyway. But stopping, sometimes just making yourself stop and intentionally take note of what's going on. And then PT really focused more on pain. Andrew, Morgan, if you want to.
Yeah. From the PT side of things, we're looking at Andrew and yeah, max assist for mobility in bed. We are going to work on that. We're going to work on the functional aspect of that. But his goals are to get out of bed and walk. Well, maybe we need to adjust that goal a little bit. Maybe we need to come up with what equipment we can use in order to actually facilitate him getting out of bed at least and being a little bit more independent. But also truly addressing what is the painful thing that's limiting him. Is it a certain way that he's doing the transfer that is causing the most pain? Is there a way that we can change that or assist so that he's not having to do a certain motion or somebody else can help it do it for him? So it's really breaking down that problem to see where can we make just a small change in order to facilitate what he wants to accomplish.
And
And
yeah, go ahead. Sorry.
And for LaSharon's part, our SLPs, are you able to eat what you desire? And it gets back to the point of, well, aspiration isn't necessarily the boogeyman. Like you have to weigh, do they want the pleasure feed? Is it worth the risk? There's a balance to be had and truly assessing where we are on that scale.
With Andrew having speech come in, which wasn't ordered at all, this is a spine surgery, right? They don't even think speech is needed, but the cog issues were concerning to us, and we weren't sure if they were disease progression or anxiety related or med related or did it matter related, right? But how can we help him? And we actually, Anna, you would have liked this one because bringing music in helped. He was a music professor. So anyway. Do we want to stop here and have questions, or what are we thinking here? Because we do have a communication training coming up in September with
yeah, let's take some questions.
Yeah, I would love to take questions. The things that we're doing are just things we're doing, and they're evidence-based and they're informed by the literature. But if somebody else is out there doing something cooler, we want to know about it. Or we could help you do something better, we want to know about it. Probably get the slides down if that's.
Hi, Anne. My name's Maddie. You have worked closely with one of my colleagues, Nicole Moran.
Oh,
I think the biggest barrier that we face is that our primary hospitals or acute cares often have a palliative team. They will be consulted and then they come over to us for rehab, and we do not have a palliative physician or any kind of formalized team. And so right now, there's kind of this gap where it stops for some patients. On occasion, we're able to send them back and kind of link those appointments so that if they're going for something else, then they can see the palliative team again too. And our one PM&R physician has a pain lens, so she's really good at that piece. But how do you suggest we justify the need? I can tell you our patients are complex enough, and you're familiar with Nicole's work to know that, but we want this, and we run into a lot of areas of why we can't have it, mostly funding wise.
Yeah. And do you have any mechanism to communicate when they're discharging to you? Is there any communication?
I work primarily on the oncology unit, and our oncology nurse coordinator will do a lot of that communication with the palliative team or their primary oncology team if necessary, but there's not one standard way. It just really depends on where they're coming from. And I think that's because the systems are really large.
Yeah. You're pointing out a great point. I mean, it's a systems issue, right? Dr. Kayloon, any thoughts?
Yeah. Maddie, are you talking about trying to advocate for having palliative care more involved in whatever in the rehab space that you're in currently, because you don't currently have a team. Is that right?
Yes.
Yes. Okay. This is an ongoing thing that I always advocate for as well. And hospital administration and leadership likes data, and you're right that they like money or showing like where the benefit is going to be in terms of funding. And so I think CAPC, the website CAPC, has information about like data in terms of how we how palliative care can save like hospital and rehab days, how they prevent readmissions and things like that. So that's information that leadership and the people filling those positions will want to see. So I would go to CAPC's website. If I don't know if Chris can put it in the chat, but I think that would probably have the most resources. But so unfortunately, it's a mix of showing that the outcomes are better for patients and families, but also that the length of stay and monetary outcomes are also favorable. That's been our experience.
And there was a recent Jerry Pal podcast, that's my favorite podcast, everybody, on, using a SNF benefit in a way that brings palliative care into those spaces. I can send that to you and Nicole, Maddie. It enlightened me because it was an interesting way of using benefits. So I don't know whether it would fly where you are, but it was recently on Jerry Pal.
Yeah, we have a SNF, but I primarily work at the long-term acute care, so they
LTAC,
need that
yeah.
3-day ICU stay to get in, and that's been a huge barrier to get anyone in. And then we also have an acute rehab unit now, but we're seeing a lot of patients who would really benefit on that unit as well.
No, I hear you. I hear you. Because we have NRH, for Georgetown, we're a MedStar system, and I feel like we just do a lousy job of of communicating. And to Bree's point, the numbers I think support us, but it takes a while to get to operationalize that research finding, right?
Yeah, but I think about this very frequently because I mean I had a family meeting today where the patient elected to go to an LTAC, a long-term acute care hospital. And they said, well, we'll give it a shot. And if I'm not thriving there, then maybe I'll do hospice. But then I always wonder, like, well, who's going to have that follow-up conversation?
Yeah.
So I think that's a piece that's missing. I agree.
Yeah, no, the communication across settings is scary to me, which to your point, Bree, in terms of outpatient palliative, if patients are going home and you can have that, you at least have that follow-up.
Yeah.
So, well, it is about time. We are all reachable. The slide deck was out there. We have enjoyed sharing our experience, but we really want to learn more from you. So feel free to reach out to any of us. Chris, I don't know if maybe that last slide we can throw with our contact information somewhere. And we're looking forward to our next talk. Dr. Jessic's here in the house. And I don't know, Max, is he in the house? I will let Chris officially.
Any other questions?
Thank you, team from Georgetown, for sharing your wisdom and expertise. Morgan, to tie it all together, wisdom was shared and certainly appreciated. I think you guys are doing great things. No facility is perfect, but it really gives some credence to the why and the importance of the effort. So I am grateful to learn from all of you and
Lori,
certainly.
Celia had one more question that's probably an important one to
I didn't see in the
go
chat.
through. Well, we have all these experts on the audience, because this is probably one that's going to take a lot of brains.
What's an appropriate response to patients who express suicidal ideation? Example, using the communication tools you've developed. And does this differ in palliative care settings versus others? Thanks, Chris.
I can start. So I have the most experience with suicidal ideation or passive death wish in the setting of somebody who does have a terminal illness. And I always struggle with, does this qualify as suicidal ideation if a patient is saying like, well, I'm in so much pain, I just would rather die. Is that suicidal ideation? Or if they say something like, well, if I'm not going to get back to where I was before, then I'd rather not live like this. So I think it's really tricky in the end of life setting to label something as suicidal ideation or not. And is this pathologic or is this normal grief? And so sometimes I'll partner with our behavioral health colleagues. And we obviously have to take any type of suicidal ideation seriously. So if somebody is expressing any kind of SI, we usually do have behavioral health see them just in case. But from my standpoint, I'm always going to be asking more clarifying questions and usually just open-ended responses like, tell me more about what you mean when you say that. So if they said, I'm so sorry, or I'm in so much pain that, I would rather not be here. Well, tell me more about what you mean by that. And they can kind of give you more clarifying answers.
I do a lot of just, this stinks. This just stinks, really just getting with them. And, I'm not offering what you're offering, but I go back to those very simple, wish it were different. Now you have some work for next time, Tim. You can start with this and we can just go right there, right?
Good thoughts. Good thoughts. Well, thank you all again for sharing your wisdom and for all of our participants for being here this evening to learn from this exceptional group and ideally imparting some of that into your regular practice and advocating for our disciplines to, really do work to improve survivorship for those living with and beyond cancer. Have a wonderful evening.
Thanks,
Thank you.
everyone.
Thanks
Feel
for
free to
having
reach out.
us. Feel free to reach out.
Take care.